Yeah, thank you, Dr. Kevin. Good afternoon, ladies and gentlemen. So for this session, we're going to have two speakers. The first speaker will be Dr. Chetan Rao, and the second speaker will be Prof. Surendra K. Sharma. So Dr. Chetan will present his talk about current and future development in lung transplantation. We know that at this moment, Indonesia hasn't, from my views, hasn't performed any lung transplantation in Indonesia. So hopefully from today's talk from Dr. Chetan, in Indonesia also we can program for future lung transplantation. And from Professor Surendra Sharma, we know that COVID-19 pandemic is probably is over, but still some patients do develop long COVID-19. So I think some experience, some expertise from Professor Surendra K. Sharma in this field. So I welcome our first speaker, Dr. Chetan Rao Vaddepally. He did his from educational background, clinical fellowship in lung transplantation in Vienna, and also did his European diploma in adult respiratory medicine in Switzerland, and got also his degree, MD pulmonary medicine in India, Telangana, and did his MBBS also in India, in Chalmeda Anand Rao Institute of Medical Science, Telangana, India, and his latest position is as a consultant in Department of Interventional and Transplant Pulmonology, Yashoda Hospitals, High Tech City. I welcome Dr. Chetan.
So very good afternoon, everyone. Thank you, Chair, for the kind introduction. And at the outset, I thank the organizing committee for giving me this opportunity to talk in front of you here. It's always an honor. So yeah, over the next few minutes, I'll be talking about current and future developments in lung transplantation. Though there are many developments that are happening, I chose to talk on few of the developments that would be beneficial in shaping the future of lung transplant in developing countries. So let me start the talk by thanking this great man, this Professor James Hardy from Mississippi, USA, and he is the first person to do a lung transplant in a human in 1963. Unfortunately, the patient succumbed to a kidney illness 17 days after the transplant, but yes, he laid the foundation for human lung transplant in the world. And only after 20 years, in 1983, this great man, Professor Joel Cooper from University of Toronto, did a successful human lung transplant, and the patient survived 7 years post-transplant. And this was possible only because of introduction of cyclosporine for immune suppression in 1983. So I'll show you a timeline. So as I said, 1963, James Hardy performed the first human lung transplant. And in 1983, the FDA approved cyclosporine for immune suppression in lung transplant. And in 1983, they did a lung transplant, but they reported the case in 1986, which was the first successful lung transplant in the world. And in 1990, they performed the first successful living-related lobar transplant. And in 1993, they carried out first lung transplant using a controlled donation after cardiac death. And 2001, the EVLP was taken into position. So this is a brief timeline for the lung transplant. And in the last few decades, there are several developments happening in lung transplant. So in the recent era, nearly about 4,500 lung transplants happen every year in the world. So the field of lung transplant has made significant advances over the last several decades. Despite these advances, morbidity and mortality remain high when compared with other solid organ transplants. And the stumbling blocks include donor shortage, proper selection of candidates, primary graft dysfunction, and chronic lung allograft dysfunction. The advances and developments surrounding these factors will have a significant impact on shaping the field within the coming years. So the 36 adult lung and heart transplant report summarized data from 69,200 adult lung transplants that have been performed till June 30, 2018, and they reported it to the International Thoracic Organ Transplant Registry. And the reported survival rates were 85% at 1 year, 68% at 3 years, and 55% at 5 years So this 55% at 5 years is better now. People have reported 5-year survival rate of 70 to 80% in the last few years. So though the registry was updated last in 2018. And this is the data from my country. This is the registry from Indian Society for Heart and Lung Transplantation. And a total of 475 isolated lung transplants and combined 128 heart lung transplants have been done in India until March 2023. Of course, there are a lot of falsities in reporting in my system, but this is the official data that has been published. So this is again data from my country. We saw a peak in the number of transplants being done from 2017 and highest being in 2018. Though COVID affected the transplant program in 2019, we still could pull off. And most of the transplants that were done in 2020 were either because of COVID ARDS or post-COVID fibrosis. This is only till March 2021. So when to choose lung transplant? That's the main question. Lung transplantation should be considered for children and adults with chronic end-stage lung disease who meet all the following general criteria. The first is high, greater than 50% risk of death from lung disease within 2 years if lung transplant is not performed, and high, greater than 80% likelihood of 5-year post-transplant survival from a general medical perspective, provided that there is adequate graft function and there is no alternative medical or surgical option available for the underlying lung disease. You must choose, but always choose wisely. And to choose wisely, you should know when not to choose. So let me go through the absolute contraindications for lung transplant. I'm not going through the relative contraindications because relative contraindications are center dependent and it all depends on your experience on doing lung transplant. So I'm just going through the absolute contraindications. The first and foremost is lack of patient willingness or acceptance of transplant. If the patient says no, it's an absolute no, you can't take it forward. Malignancy with high risk of recurrence or death related to cancer, acute coronary syndrome or myocardial infarction within 30 days, stroke within 30 days, liver cirrhosis with portal hypertension unless being considered for a double transplant, that is liver plus lung, acute liver failure and acute renal failure, septic shock, active extrapulmonary or disseminated infection, active tuberculosis infection, HIV with detectable viral load, limited functional status, progressive cognitive impairment, active substance user dependence, and other severe uncontrolled medical condition that is expected to limit the survival post-transplant. So these are the absolute contraindications for lung transplant. So let us look at the two time frames when it comes to lung transplant. The first is the timing of referral. This is the time where a physician refers a probable candidate to a lung transplant program. So we recommend the timing of referral should be as early as possible because it allows us to optimize the patient, to introduce the concept of lung transplant to the patient, and to correct the correctable causes to have better success rates post-transplant. And the next is the timing of listing. And this is the time when we actually place the patient in the active waiting list for transplant when we think it is the right time he would benefit from a transplant. So this is the latest updated data from ISHLT registry regarding the adult lung transplants by diagnosis from January 1992 to 2018. If you can see in the first column from Jan 1992 to 2000, the most common condition for which transplants were done was COPD. But in the last decade, IPF has taken over, probably because more and more cases of interstitial lung disease have been diagnosed and the awareness about interstitial lung disease has picked up. So this is the major indication for lung transplant right now. And even in my country, we see more of ILDs done, but it is more of chronic hypersensitivity pneumonitis that we see. And this again is pediatric lung and heart transplants, lung and lung transplants. So it's always been consistent. The major condition for which the main condition for which it is done is cystic fibrosis, and that remains the same. So let me go through the current developments. As I said, I am going through only specific developments that are important in shaping the transplant, the future of lung transplant. So the main thing is to address the donor shortage. So each year, approximately 10 to 13% of listed candidates die while on the waiting list, and the lungs are used from eligible multi-organ donors only 15 to 20% of the time. 80% of the time, we tend to reject the lungs from a multi-organ donor. So what are the ways to overcome this problem? Use more of DCD donors, use of extended criteria for donor selection, ex vivo lung perfusion, and utilization of bioengineered lungs. So what are the characteristics of an ideal donor? Age less than 55 years, clear chest radiography, PF ratio of more than 400, less than 20 pack years smoking history, absence of chest trauma, no signs of aspiration or sepsis, sputum or endotracheal tube aspirate negative for bacteria and gram stain, and normal bronchoscopy without significant secretions. Unfortunately, you tend to reject 80% of the lungs if you stick to this criteria. So people have moved away from looking at ideal donor to an extended donor, or the other ways that I would be talking hereafter. So let us look at the donation after circulatory death. So in this case, organs are procured from a potential donor in whom life-sustaining therapies are being withdrawn and is declared dead after cardiac arrest. So the use of DCD in lung transplant become a clinical reality in recent era, and reports suggest that up to 30% more donors can be identified this way. Although concerns exist about the logistics of DCD recovery and about the quality of DCD lungs, the growing experience has demonstrated equal and perhaps even superior outcomes because of avoidance of cytokine storm and inflammatory state that often accompanies brain death. So this is the first initial data that has come up in support with a DCD. So this was a study where they compared the survival of DCD donors with DND donors. So DDCD is death after determination of circulatory death, DD is death after determination of neurological death, and they compared it with the ISHLT registry data from 2006 to 2011, and they showed that the survival was in fact better in DCD donors as compared to the brain dead donors, and this was way back in 2011. So what are the favorable outcomes of donation after cardiac death in lung transplantation? And this is a multi-center study, one of the oldest and major study that was done in regards of this. So this was done from January 2003 to August 2012 in 9 centers in North America, Europe, and Australia. And they concluded that the 30-day survival was 97% in both groups. 1 year survival was 88% in brain dead and 89% in donation after cardiac death. So overall, the donors from cardiac death are underutilized in many of the countries, more because of the logistic reasons. And if you can get this into your lung transplant program, you get up to more than 30% of lungs. So we will see about ex vivo lung perfusion, which is another major development that can improve the quality of lungs, at least from a marginal donor. So EVLP involves taking lungs of uncertain quality or in which further evaluation is desired and placing them on a device on which they are ventilated and perfused with an electrolyte and protein solution for a matter of some hours, allowing for an extended evaluation outside the donor. And this is a normothermic procedure. The temperature is taken up to 37 degrees. This is not a cold procedure. So this serves to recondition lungs that previously might have been unacceptable and discarded. And this has shown that you can increase your donor pool at least by 15 to 20% if you can successfully do an EVLP. So this is an EVLP circuit. You have a catheter from a left atrium that drains into a reservoir, then a gas exchanger, then it's pumped back into the pulmonary artery, and you measure arterial gases, you measure a pulmonary artery pressure, and over 6 hours you evaluate them and then decide if they're acceptable or not. So what are the pros? Evaluation of lungs under continuous physiological monitoring, because this is a normothermic procedure. Reconditioning lungs with fluid removal. Intervention or engineering of lungs with intense therapy and extended preservation time. And what are the cons? It induces inflammation, compromised cellular metabolism and mitochondrial function, disrupted microcirculation, and ventilator-induced lung injury. And let me tell you, the first lung transplant that was done by James Hardy was a lung from a cardiac death patient. So currently there are 3 major EVLP protocols with different underlying rationales: the Lund protocol, the Toronto protocol, and the probable EVLP protocol. And the most commonly used is the Toronto protocol. I'm not going into detail of it. So further evidence is needed to prove which protocol is superior regarding each major role of EVLP. That is, are you using it for lung assessment? Are you using it for reconditioning? Or are you using it for lung preservation? So how do you accept or decline the lungs after 4 to 6 hours of EVLP? Acceptance criteria: PF ratio should be greater than 400, stable or improving pulmonary artery pressure, stable or improving airway pressure, stable or improving pulmonary compliance. And you exclude the lungs, you reject the lungs after EVLP if the PF ratio is less than 400, greater than 50% deterioration on pulmonary artery pressure, and greater than 15% deterioration on airway pressure or compliance. So this is the first study that looked into the utility of EVLP lungs, that is on normothermic ex vivo lung perfusion in clinical lung transplant. And this was again from Toronto. This was a single center prospective non-randomized clinical trial. The total transplants done during the study period were 136, and out of which EVLP were 23. And they concluded that the incidence of primary graft dysfunction at 72 hours after transplantation was 15% in EVLP group and 30% in the control group. And so the incidence of primary graft dysfunction is actually lower in the EVLP group. And there was no significant difference observed for any secondary endpoints, and no severe adverse events were directly attributable to EVLP. And this laid a foundation to further take EVLP into the lung transplant programs. And this is a major meta-analysis that was done: ex vivo lung perfusion versus standard protocol lung transplantation regarding midterm survival. And this is a meta-analysis, the largest meta-analysis done till date. So 13 studies met the inclusion criteria with a total of 407 EVLP lungs and a total of 1,765 standard protocol lungs. So the majority of donor lungs were from brain dead donors, with EVLP lungs having significantly worse PF ratio and significantly greater rate of abnormal chest X-ray. There was no significant survival difference for EVLP or standard protocol at 12, 24, and 36 months. And meta-analysis did not find a significant difference in the risk of 30-day mortality or primary graft dysfunction grade. So most of the studies that compared either DCD donors or EVLP donors were not to prove the superiority of the procedure. They were done to prove that they're equally beneficial. And this is the survival post-transplant. The blue line is the EVLP lung and the red line is the standard lung. And there's no major difference in survival even at 12, 24, and 36 months. And this is the meta-analysis of all the 13 studies. And they concluded saying that EVLP offers the potential to increase lung donor utilization while providing similar short-term outcomes and mild to long-term survival. This is an interesting development: living donor lobar lung transplantation, again done in very selective developed lung transplant programs. Not everyone can do this. So donor lobar transplantation is performed as a life-saving procedure for critically ill patients who are unlikely to survive the long wait for cadaveric lungs. This is developed by a group in University of Southern California in 1993 and should be performed under appropriate circumstances considering the inherent risk to the living donor. So what are the advantages and disadvantages of this? Advantages are short waiting time. There is short ischemic time because you have both the donor and recipient on the table at the same time and you can coordinate and do it. Perfect graft with less injury and infection because you properly select the donor. You have full control over the donor. You can schedule operation at ease and similar HLA. So most of the donors for this procedure are first degree relatives. And the disadvantages are lobectomy in healthy donors. Size matching is very difficult and you need 3 operating rooms with 3 teams. So for this procedure, you need 2 donors and a recipient. So the right lower lobe is implanted as the right lung in the recipient and the left lower lobe from the second donor is implanted as the left lung in the recipient. And this is how size matching is done from Dage formula based on predicted FEC. And this is the 5 and 10 year survival rates published from Kyoto University in November 2021. So the red one is from living donor lobar lung transplants, and this is the conventional lung transplant, and the outcomes are similar, in fact better in living donor lobar transplants. But this comes with a lot of expertise and you need a lot of experienced surgeons to do this. So the next one is more of a medical perspective, doing an extracorporeal photopheresis. also known as extracorporeal photoimmunotherapy or photochemotherapy. It is a leukapheresis-based therapy which was initially used in patients with cutaneous T-cell lymphoma. Additional indications have been successfully explored, including areas such as graft versus host disease, scleroderma, and solid organ transplantation. And this procedure is incorporated into lung transplant programs to treat acute cellular rejections. In fact, more than treating, it helps in reducing the rate of fall of FEV1 post-transplant in patients with rejections. So this is a illustration. The whole blood is drawn from the patient. Plasma and WBC are separated and are passed through a circuit where they are exposed to 8-methoxypsorelin and ultraviolet A rays. So the mode of action is still vaguely known. Different immunomodulatory mechanisms have been postulated, including the stimulation of cytokine release, that is IL-1, IL-6, which may then affect the whole immune cell population. Moreover, production of clone-specific suppressor T cells, induction of lymphocyte apoptosis, or alterations in the T cell receptor may be possible, because acute cellular rejection is all about the cytokine release from these inflammatory markers, and this procedure aims at suppressing this inflammation in the recipient. So this is one of the initial studies that looked into extracorporeal photopheresis after lung transplant. This is a 10-year single center experience where they did it for bronchiolitis obliterans and recurrent acute rejection after lung transplantation. And as I said, the rate of forced expiratory volume in first-second decline was used as a primary measure, and graft survivor post ECP as a secondary measure of efficacy. So 24 transplant recipients were included, and in recipients with Bose, decline in FEV1 was 112 milliliters per month before the start of ECP, and it reduced to 12 milliliters per month after 12 ECP cycles. And there are no ECP related complications that occurred. So apparently it is a very safe procedure with no side effects. All your immunomodulatory drugs or immune suppressive therapy have come with a lot of adverse effects, and sometimes they can even be fatal. This is one therapy which has absolutely no side effects, but at the same time, it has no mortality benefit whatsoever. It just slows down the fall in FEV1, but it doesn't have any mortality benefit. And the same was again concluded from a prospective interventional study from Vienna. And this was one of the later studies again from Vienna, where they looked into outcome of extracorporeal photopheresis as an add-on therapy for AMR. So far, it was done for only acute cellular rejection, and this is the first time they have looked into extracorporeal photopheresis as an add-on therapy for AMR. So when I say it as an add-on therapy, it is after managing your antibody-mediated rejection as per your local guidelines, then you put the patient on extracorporeal photopheresis, and they found that the results were maintained for a prolonged period when you add this extracorporeal photopheresis after antibody-mediated rejection. So both the HLA class 1 and HLA class 2 antibodies were maintained at very low levels for prolonged duration when the patient is put on extracorporeal photopheresis. So in conclusion, this retrospective analysis reports about the first experience with ECP as a treatment of AMR after lung transplant. And they hypothesized that after clinical improvement driven by first-line treatment, ECP triggers immune tolerance, thereby improving long-term outcomes, and there are no side effects. These were some of the important current developments that are already in practice in the developed nations, which would shape the future of lung transplant in developing nations. So let me take you to some of the future fancy developments that are happening in lung transplant. The first is non-invasive biomarkers. People started looking into non-invasive biomarkers like this torcotinovirus, because most of the available biomarkers for be it infection or rejection are all pharmacokinetic. So it depends on population, differs from patients to patient. So this torcotinovirus are persistent small non-enveloped single-stranded DNA viruses that belong to family Annuliviridae, and they are present in about 90% of human population. So the level of torcotinovirus increases when the immune suppression is more, and the level of torcotinovirus decreases when the immune suppression is less. So based on these levels in the blood, you can decide your margin of immune suppression, and they have come up with some data saying if you maintain this within these levels, the chances of infection, the chances of rejection are very low, but this leads a lot of validation, proper reference values for this. Are we looking at xenotransplantation? Yes, there are studies going on, but so far it is from a different species of animals. None of it was transplanted into a human. Hopefully, we will get to see it soon. Then bioengineered lungs. Yes, this is also happening, but again, there are a lot of drawbacks in this. So bioartificial lungs created by combining native matrix scaffolds. That is, you take a native matrix from a cadaver lungs, and then you have to put patient-derived cells onto it. So bioartificial lungs are transplantable, similarly to donor lungs, but the scaffolds preserve the vascular and airway architecture. So they don't have the need for immune suppression because it is the patient-derived cells. Waitlist is not required, and there are no concerns related to immune suppression, including infection, cytopenias, renal failure, and even perhaps chronic rejection. So far in the investigation phase, these are done on biosynthetic membranes, which are actually not suitable for human lung transplantation. So people are looking at doing this on the lung scaffolds from cadaveric organs. So this is how it is done. First, the cadaveric lung this is a porcine lung. The cadaveric lung is taken and it is subject to a process of decellularization. And this is how the lung looks after decellularization over 24 hours. Absolutely no cells, just the matrix of the lung there. And then later, the process of recellularization starts. You take the patient-derived pluripotent cells and start incorporating into the decellularized lungs. And then again, you regenerate a new lung with the patient-own cells. So there is theoretically no risk of rejection, and you don't have to do any immunosuppression because it is all the patient-derived cells. Hopefully, we will get to see this soon. And yeah, let me also tell you about the other developments like robotic transplantations. There are already reported cases of successful robotic lung transplantation in the United States and Spain. People are looking at uniportal VATS related lung transplantation to minimize the surgical complication. So this was all something about the current and future developments of lung transplantation. And let me take you through few slides of our recent transplant. So this was a patient who was referred to us from another state called Kerala, which is the most southern part of the country. He had been diagnosed with fibrotic ILD 2 years back, and is been on long-term oxygen therapy for the last 1.5 years with 3 exacerbations in the last 1 year. And when he was referred to us, he was on 5 to 6 liters of oxygen every day and was even unable to get out of the bed. Then we evaluated him for transplant. We optimized him with whatever resources we had. And as and when we got a suitable lung, we went and did a bilateral sequential lung transplant. If you look at this video, this is his native lung, the fibrotic lung. You can see the compliance, that is pretty bad. And this is a transplanted lung. See how healthy and beautiful it is. Nothing better than this to see for a surgeon on table. And this is after completing the bilateral lung transplant. And this is the patient comfortably sitting in chair on 3rd day of transplant. We extubated him on day 2, and this is the 3rd day. This is day 5. We concentrate more on aggressive physiotherapy immediate post-transplant. The earlier you mobilize, the better the results. And this is day 7. He was off oxygen, and it was a moment of pride for the family to see him off oxygen and walking after 1.5 years of struggle. So finally, we discharged him exactly on day 15, and after 1 month, he flew back to his home. So it's a major achievement when you actually discharge a patient on day 15. Not every patient goes back home after 2 weeks. So this is a beautiful team that I work with. Thank you.
Thank you, Dr. Chetan, for this interesting presentation, for sharing your experience in lung transplantation in India. So before I proceed to the next speaker, are there any questions for Dr. Chetan from the floor?
Thank you, Dr. Chetan. My name is Rio. I must confess, I'm still new. This is a good insight for me. I just know that lung transplantation is already success. Thank you for the video. Maybe I would like to share your experience. How about to find the donor criteria? Is it like kidney transplantation? Is it family or is it I just maybe this is a general question. I'm sorry, but I would like to know. Thank you.
Yeah, thank you so much for that. So most of the lung transplant is only from deceased donors, except for that living lobar donor transplantation, wherein you take the lungs from a family member, and that is done mostly at very few centers, and it is still a lot to be investigated about that. But most of the programs are from deceased lung donors, either from brain dead patients or after donation of the circulatory death. And these DCD donors are still not available in all the countries. India doesn't have DCD, we only do brain dead donors. So the lungs are taken only from deceased donors after confirming either brain death or circulatory death.
Yeah, thank you. Any other questions? So, Dr. Chetan, like in Indonesia, we have been performing liver transplantation, we are performing kidney transplantation. So, the patients, the recipient, usually we give vaccination, pneumococcal vaccination, and also isoniazid preventive therapy for latent tuberculosis. So, can you share your experience? Were those recipients, this lung transplant patients in your institutes given the same vaccination program or any other vaccination program?
Yeah, so thank you for that. We also have a vaccination schedule. That's the reason we ask the physicians to refer a patient early. So most of the pulmonologists who are familiar in treating end-stage lung disease already do the flu and pneumococcal vaccinations for all end-stage lung diseases. So at least 90% of the patients, by the time they reach us, they are already vaccinated for that. But we have an adult vaccination schedule that is designed by our infectious diseases team, which includes all that pertussis, diphtheria vaccines, and rest all meningococcal and all the rest adult vaccinations also. We tend to finish them as much as possible because you will not be able to give live attenuated vaccines after the transplant in view of immune suppression. And even the other vaccines, you are really not sure of their efficacy because of the immune suppression post-transplant. And regarding isoniazid, yes, that is a major problem in developing countries like you said, Indonesia, and even in India, because they are endemic for tuberculosis and we have a lot of tuberculosis burden. So we always screen patients for latent tuberculosis. And if they are positive for latent tuberculosis, we give isoniazid prophylaxis pre-transplant. And if by any chance, if you're not able to complete the prophylaxis, we still go ahead, do the transplant and continue it after transplant. And if there is active disease after transplant, we treat it with the full anti-tubercular therapy.
Okay. One last question, Dr. Chetan. Like India, Indonesia, and also China is endemic for tuberculosis, and patients recover from tuberculosis. Usually they have this destroyed lung. Have you have any experience performing this lung transplantation in post-tuberculosis destroyed lung patients?
Yeah, so I absolutely like this question because I keep breaking my head every now and then when I see these patients. So as you rightly pointed, the major problem with these patients is the disproportionate thoracic cavities. You see one completely destroyed lung and one overinflated lung to compensate for the other lung. And the problem here comes first is when you want to do a size match, because you have two different disproportionate thoracic cavities. You can't go with your regular size matching technique. So what we usually try to do is take a lung that is oversized, at least 120% of the predicted TLC, and because the one lung is already overinflated, the lung compensates for that, And the other side where there is destroyed lung, you might have to do a lobar transplantation. If per se the left lung is destroyed and the right lung is overinflated, so overall you take a 120% predicted lung, implant the right lung as it is, and left maybe you can just go away with a left lower lobar transplant. So that is how we have been doing. But there is a lot of surgical risk in these cases because there is extensive pleural reaction and adhesions. They tend to bleed a lot on table.
Okay. Thank you, Dr. Chetan. Let's give a big applause for Dr. Chetan on his plenary lecture about lung transplantation, and hopefully we also in Indonesia can start this lung transplantation program. So I continue with our second speaker for this plenary lecture. So may we welcome Professor Surendra K. Sharma. Are you with us, Prof?
Hello.
Yeah. Hello, Prof. So can you share the CV of Professor Sharma? CV, curriculum vitae. So Professor Surendra K. Sharma, he will present a talk about long COVID-19 beyond acute SARS-CoV-2 infection. And this is the educational background of Professor Surendra K. Sharma. So graduated from Indira Gandhi Medical College 1973 and did his postgraduate Institute of Medical Educational Research in Chandigarh, India 1978. PhD in AIIMS, All India Institute of Medical Science in New Delhi 2003, and his latest position is has a current affiliation adjunct senior professor in Jamia Hamdard Institute of Molecular Medicine, New Delhi, and also in JNMC Datta Meghe Institute of Medical Science, Wardha, Maharashtra. So we welcome Prof. Surendra K. Sharma. You may present your talk, sir.
First, I will like thank you very much the organizing committee, GICC, IM 2023, and especially I will like to thank Dr. Gurmeet Singh for inviting me to give a talk on long COVID in this plenary session. And I want to acknowledge help of Professor Adi Mohan. I have borrowed two slides from Acute SARS-CoV-2 chapter. I don't have any declarations. I don't have any conflict of interest. And although I have borrowed from our published chapter, the figures I will be showing later on. And we didn't have any financial support for this talk. And objective of this lecture on long COVID will be actually to that audience at the end of lecture, they should be familiar with several nomenclatures and definitions, various risk factors and predictors. What are the effects of vaccination and oral antiviral treatment? What is the epidemiology? A lot of variations, in fact, and several risk factors. What are these risk factors? And involvement of different organs and recent description of various phenotypes with the long COVID. And what are the prevention, treatment, and long-term care issues? These issues actually, this appeared on 8th of June this week on Thursday, which, when actually New England Journal of Medicine new issue comes. So there are two perspectives. I will be discussing those also, that what the authors have raised the issues about long-term care, etc. And just actually on 25th of May this year, NIH has published results from the Recover Consortium clinical trial. And I think this will be giving some idea for the future. And I will be deliberating on Recover and UK's initiative on research. Now, actually, we are witnessing this and coming across this pandemic 3 years on, and just in the first week of May, WHO for the first time has declared that pandemic is over, but has cautioned about taking precautions. We have seen that several in the beginning, actually, this disease has got several nomenclatures like long COVID syndrome, post-COVID-19 conditions, post-COVID-19 syndrome, long haulers. And the last one is the most accepted nomenclature for long COVID. I think I will like to draw attention of the audience that it was not the medical health or the healthcare provider community that first proposed that there are patients with long COVID, but it is the actually patients group which came forward for the first time. And actually, if you read initial publications, so they said actually that we are experiencing, once the acute illness is over, they are experiencing persistence of some symptoms, and healthcare provider took it very lightly. In fact, if you read some of the initial publications where actually it was dismissed as nothing unusual. So I think we must acknowledge patients group who proposed for the first time that they are experiencing very unusual symptoms which are persisting for a long time. And let me also share that there is no standard definition. And these people have wide range of symptoms. Diagnosis is by exclusion. And there is no unified pathophysiology, and this is very unfortunate that we don't have any laboratory diagnostic test or biomarkers for this condition. And it involves multiple organs, and patients usually present with several symptoms which can be clustered and can be grouped under phenotypes, various phenotypes. If you just have a look at this, that patients were, I don't want to go into the details of acute SARS-CoV-2. Actually, we have come a long way from that. But just to share with you that one gets actually very scared to see that type of situation one was in. That is actually that patients were getting hospitalized. Then during Delta wave, we have several mortalities. Actually, I think here in our country, especially in North India, actually, people lost their loved ones from each family. Actually, there was a heavy mortality. And we have come this thing from that. Actually, we have come over with the syndrome, which is going to be there for a long time, and various terminology by scientific organizations have been given for this long COVID syndrome. So nice guidelines say that I think the most important point here is the timeline when you start suspecting. So there is a difference between WHO, CDC, and NICE guidelines. The timeline actually proposed by CDC Atlanta is that it is persistence of symptoms for 4 or more weeks. Once actually patient has experienced, experience means actually not uh, uh, without a laboratory proof, that is RT-PCR positive. It has to be RT-PCR positive, and so CDC says 1 month after that actually there is a persistence of symptom. WHO on the other hand says that it is 3 months, 12 weeks, but actually after 2 months you have to be the patient actually usually persists with some symptoms, and they last beyond 3 months. And important thing about these guidelines, whether it is you take 4 weeks or 12 weeks, that there should be no alternative diagnosis or mechanism to explain his persistence of symptoms. That is very important. Actually, that is, I think, one needs to understand before one goes to several series, etc. Predisposing factors, actually, we know that elderly individuals or say 36 to 50 years of age, or these are actually the risk factors for development of COVID, and naturally, subsequently, some of these will have long COVID. Important thing is that older the individual, more chances, and it can occur in hospitalized, non-hospitalized, in very severe, mild. Those are symptomatic or asymptomatic cases also. So, but I think whatever review I could do, that the essential criteria, lab criteria, that they must be RT-PCR positive. Now, this is about risk factors for long COVID, and what actually this slide shows that female, there is interaction of several risk factors, and there are ongoing several laboratory-based studies, and we have data from electronic health records and symptom surveys which were telephonic, online, which may not be that reliable, in fact, because these are reported by the patients. There were no physical examination done. So there may be overstatement about or over representation of prevalence rates. That is the problem with this at currently available prevalence data. And if you look at the right side of this slide, that shows that female gender is much more predisposed to get long COVID, and more the severe disease, there are more chances of developing long COVID, type 2 diabetes, and higher the viral load. After all, the virus is going to persist in the tissues when it is circulating and getting lodged in several tissues. So that is the, I think I will be showing in subsequent slides what is the basis of multiple organ involvement in long COVID or COVID as such. Then simultaneous reactivation of latent viruses like EB virus and human herpes 6 virus, and autoantibodies also against various organs are going to play very important, they are playing very important role, but long-term studies which are ongoing right now, we are eagerly waiting for the results. This is the model of interactions which shows that there is this shows that biological factors and triggers and experiential factors, psychological factors, All this will in the background of genetic predisposition, personality, and person having poor social support and biological effects of chronic stress will and we know that social factors were very important, which played role, especially lockdown, etc., getting emotional patients getting into emotional mode, and and some of the patients having illness perceptions and illusion about death, impending death. So that all actually these all in the background in his mind actually. So this will also play a role in development of long COVID. Now, what are the predictors? Let me first actually, I have talked about the risk factor for development. Now, actually, I'm talking about predictors of going on with the persistence of symptoms or long COVID. There are two things which are protective. One is actually vaccination status. I will be showing you the compelling evidence which comes from there are several studies available now that says that if you have vaccination done, so it is protective. The another thing is actually use of oral antivirals. Unfortunately, most of the developing nations were not able to get access, and these were not available in the free market also. But highly developed country like US, they were able to, patients were able to get. And here the rider is that if the patient has got mild to moderate disease, and if you are having several risk factors and you suspect that patient will progress to develop very severe disease, here the rider is that the drug has to be used within the first 5 days of illness. That means actually once you are diagnosed, confirmed case, and it was used within first 5 days, the chances were less. This study actually was published just a couple of days ago. This study is giving preliminary evidence, but actually I am not sure, because sometimes things are pharmaceutical company driven also. So there is a big question mark whether that there is a pressure to use this drug even within asymptomatic or patients with mild symptoms who are RT-PCR positive, because still actually further subvariants of Omicron are prevalent, and people are coming with, for example, people who are incidentally getting tested and they are coming out to be positive. It has actually come here to stay, just like H1N1 viruses, flu viruses, etc. The another actually is I have discussed the interaction model and viral load, etc. I have discussed the medical comorbidities. Everyone is aware. I need not go into the details. Now there is a. This is what I was saying, that there is a compelling evidence that development of long COVID or protection is directly related to the vaccination, and there is a dose response relationship. That means actually more number of doses, less chances of getting long COVID. So I think the message this slide wants to give that we must persuade people to get vaccinated, not only COVID, but other vaccinations also, because it has got preventive effect. This shows actually risk of COVID associated with variants and number of doses. If you look at odds ratio, having long COVID will decrease as the time passes, vaccination more than 6 months in all age groups. And it is more apparent if one is talking about elderly individuals, and what we saw actually as the pandemic progressed, original strain, then we had a Delta, which was very lethal strain, in fact. And incidentally, we didn't have, some countries were fortunate enough to have vaccination, but most of the countries could procure. And for example, India could develop its own vaccines. Actually, I think Indian manufacturers must be complemented here because it has played a lot of role. So Omicron as actually Delta versus Omicron variant of SARS-CoV-2, and the number of doses if you increase across all ages, but especially the protective effect. If you look at the odds of developing or getting protected, here is 74%. It's a huge actually advantage. So the message here is that the reduction in odds of long COVID will decrease substantially with the Omicron variant versus the Delta variant and vaccination. And although it will depend upon how much population is vaccinated and how much is the population, and then multiplied by number of people affected. So numbers might, absolute number might increase, but it does give, this is, I think, very compelling evidence from this slide that vaccination is protective. Now actually looking at what is the epidemiology. Epidemiology, what if you read X number of publications, you will get confused. What is the actual incidence and prevalence and global burden? So in the early on studies, one found that prevalence is very high. So people were discussing up to 3 months or few weeks. It was to the tune of more than 50%. But I have delivered several lectures actually on this topic. So what I have understood is that recovery is a function of time. Patients will recover, and the recent publications also show the same trend. Most of the people will recover from long COVID symptoms by 6 months to 1 year. But people might have persistence of symptoms for nearly 3 years. There were actually when this scientific patients group and scientific organization, they recognize the entity of long COVID. National Institutes of Health US and National Institute of Health and Care Research UK, both of these actually awarded research projects. US awarded 1.5 billion over 4 years for 40 research multidisciplinary projects, and 4 projects were awarded by UK. And you look at the huge amount of funding which has gone into this. And I was sharing with you, I will share with the early findings of Recover consortium clinical trial. So there, so we come to this thing conclusion that true prevalence of long COVID is unknown. This is because actually I was saying that electronic health records have been used, and initial studies actually provided prevalence data on prevalence very high. This was because of varying definitions and method of analysis, and these were online surveys and telephonic surveys. So there is a big question mark on reliability of data, reporting, self-reporting by patients. No physical interview took place where physician could verify the physical findings, etc. And these actually studies come from some from Europe, some from North America, dominantly. So we can, and marginalized communities also. So we cannot say much right now. And all along, actually, from 2019, late 2019 and early 20, we have actually mutations going on in the virus. So various mutants appearing, which over the period, actually, this virus became less lethal, and vaccination also came in, and oral antiviral agents were also available. This is important study which appeared in JAMA in 22, and this is the systematic review and meta-analysis done of long COVID using, they have used WHO definition. So this gives prevalence of say 1 in 15, and females here also dominate, and persistent fatigue with body pain, mood swings, respiratory problems, cognitive problems. And the conclusion of this slide is actually that overall in every subgroup, this is actually by say 3 months after symptom onset, 12 months. So this is between 3 months and 12 months overall. In you look at the all individuals, how the number is going down, and overall in every subgroup, women are more likely to suffer from long COVID. Hospitalized patients more prone, and the proportion with long COVID decreases. There is substantial decrease if you look at the second column. These are actually, I want to share with you these findings of long COVID. So this is a post-acute sequelae of SARS-CoV-2. This is the accepted term, and the early findings of recovered consortium adult. This appeared in JAMA last week of May, and these were the most you might be aware of all the. I need not go into the details. Most prominent symptoms. These are most prominent symptoms, and what it says actually that 1 out of 4 participants met definition criteria, and 4% without a history of COVID infection had long COVID. Correlation of higher score was with unvaccinated individuals infected with earlier strains, as I have been highlighting. That earlier strain was were actually left people with more sequelae, and most prominent symptoms were post-exertional fatigue, central nervous system. Actually, patients will say, they complain that we just don't want to get out of bed. Just lying on the bed, they say that they have a complete loss of energy. I have also seen in my clinic patients that they have, some of the patients had hair loss, etc. also. And anosmia is actually prominent in least severely affected. This is most severe cases will have these, and these are these actually CNS and other effects. Let me also tell you that we used to see, we have seen several pandemics previously also, though these were lasting for a brief period. And we are very much aware with the myalgic encephalomyelitis and chronic fatigue syndrome. And there is some sort of psychological disturbances like depression, etc. also. Some patients experience in long COVID experiencing this. Now actually this editorial, there was editorial also on this same thing actually that covered trial results. So what this says actually that what actually they have seen in the recovered trial, clinical consortium clinical trial, the features are similar to post-intensive care syndrome. the people who are dealing with critical care and ICU, etc., they might be aware of when patient is ventilated and then liberated, and then they have actually some persistence of symptoms after discharge also for quite some time, few weeks. And similarly, as I said, myalgic encephalomyelitis and chronic fatigue syndrome. Why women are more prone? Actually, I think we should also discuss this because they elicit very strong. You must be aware that, for example, autoimmune diseases as such are much rheumatoid arthritis, Hashimoto, etc. They are much more common in females. Likewise, long COVID is also much more common in females. There are several explanations, and you might be aware. But actually, here higher exposure to virus in certain occupations such as nursing and education, which can predispose them to higher incidence of disease as such and development of long COVID. So this is actually, I just want to show you that ACE2 receptor is present in almost every organ. And therefore, actually, there is a multi-organ involvement. And this is a publication, it's quite good publication, I must say, that it appeared in Nature Review Microbiology 2023, very recent. So actually it shows that autoimmunity is also important driver. Mast cell activation syndrome, this also has been proposed. Then people have disturbances in the gastrointestinal tract. There can be kidney injury, renal injury, and hematological system may be affected, and several explanations have actually that this virus is thrombogenic virus and it can result in fatigue and neurological symptom. This is the, I think this is the most prominent: cognitive impairment, fatigue, and memory loss, tinnitus, etc. And you must be aware in your day-to-day practice that the post-COVID, actually we have got higher incidence of new onset diabetes also. Because of pancreatic injury and persistent post-COVID fibrosis, everyone knows. I need not go into the details. Even actually reproductive system has not been spared. And it's again actually highlighting same thing, that clotting disturbances and dysfunctional neurological signaling and autoimmunity and microbiota dysbiosis and immune dysregulation because of viral persistence in the tissues. I think that is the most important. It is giving actually stimulus, persistent stimulus to T cell, B cells. So these are most prominent symptoms. I did not go into the detail, like mood changes, patient feeling very tired, and having actually insomnia, etc. Brain fog, actually everyone must, media also covered this in the initial part, that people are experiencing brain fog. That there is a problem with cognition, memory, etc. And cranial nerve affected because led to loss of smell or change in the taste. These are actually phenotypes of various. They have tried to. Only thing when I was looking at this slide, I think that they have left out cutaneous, especially appendages. Like some of the patients I have seen, they have complained hair loss. So I think that must be kept in mind. And these are actually if you look at this slide very closely, at that most frequent persistent symptoms, 33% fatigue. This is what I was saying. Dyspnea is obvious because the lung is the commonest involved, but some of the patients do recover, and some of the patients recover completely. That is another point, actually. Myalgia, etc., may be there. And myalgic encephalomyelitis, I have been saying, and chronic fatigue syndrome, we are aware of. But I must say, if the time permits just 2-3 minutes, I would like to say, New England Journal of Medicine, which is, I think, everyone reads it every week. It appears. I was referring also to the previous this week's publications that in late 2022, it carried actually the mechanism. Actually, I think everyone should read that what leads to cognitive impairment. This is the activation of microglia, and these are macrophages like cells, and this leads to brain dysfunction. There is a neuroinflammation, and which leads to this. It takes time for recovery actually, and this is actually what actually this slide shows. Very important point that both MRI were pictures are normal, but PET CT, which usually say that it is not useful for brain imaging, but here actually it picked up that long patient with cognitive complaints, cingulate cortex was affected, and it is this is the patient with long COVID. I have been saying that there are no lab tests, there are no imaging tests, but actually I don't know across these developing nations, people may not have facilities for doing PET CT. It may not be available, excessive. People may not access this facility. So there may be some difficulty because it has to be done for other diseases also. So one needs to see with time actually that how much this was the earlier publication in Journal of Neurology. Then actually one very famous study which appeared that these patients with the COVID will have dyslipidemia, and this was done actually in military newly recruited military personnel, recruits. So what they found, these were young people actually. What they found that significant degree of dyslipidemia occurred. Now this actually is a cross-sectional study. It's very difficult to say whether it will translate into long-term. If the follow-up is done, only then we will know the answer whether these people will get cardiovascular complications or not. POTS actually, I did come across several patients, and everyone must have experienced during the acute phase that we were experiencing people with, I actually even had young patients presenting with 140 without fever, heart rate. And this has persisted in few patients after COVID subsided. So POTS is a manifestation that is postural orthostatic tachycardia syndrome, and we were actually taught in undergraduates and postgraduate courses that there are set criteria. One should, I will not go into the details. I think every one of you might be aware what is POTS, but one must keep in mind that if the patient had past history, there is no other alternative explanation for tachycardia, and these are the criteria which are fitting in with that patient. Then actually, and the important thing is there should be no hypotension. So there has to be as far the treatment is concerned, supportive. And there are actually some drugs which are under trial, but everyone is aware that montelukast was used ad nauseum. Everyone used this actually when people have acute, but this might have a role in chronic long COVID also. Pirfenidone and nandinimab, these two antifibrotic agents, everyone has used. Naltrexone is an anti-opioid. There are reports, but long-term studies are going on. Ivabradine, everyone has used. I have used actually, I think, in hundreds of patients during COVID, acute and post-COVID also. Very good drug, in fact, and it does control heart rate. And this is what actually the I think important slide, which shows that there are two aspects which become problem for the patient. One is actually physical, the another one is mental. So what they have suggested rehabilitation models, and what they say actually that a patient, if they are actually can be treated at home also, at the community level also. Then if they have several organ involvement, multidisciplinary team care with a regular follow-up should be provided. So this also shows that now actually if someone is unvaccinated and develops long COVID, symptoms suggestive of long COVID, so there is a big question mark actually, and these studies, most of the advice is that there is no utility of in vaccinating them, but it has to be done prior actually, and so that it doesn't develop. Slight convincing, compelling evidence I shared with you. This is the this appeared on June 8, this week on Thursday. Actually, there are two perspectives which have appeared, and there are 4 authors. And what they are saying that for the first time, actually, I think this is important slide, that International Classification of Diseases is giving code U09.9 to help nation document visits to the healthcare system. And this I have discussed that here actually I am adding post-traumatic stress disorder also from psychiatrist point of view, or auto-traumatic experiences of this illness. And we don't have effective treatment because we are not very clear right now about the exact pathogenesis. And what actually I think it needs to be appreciated, which has not been that adequately appreciated, that there was a remarkable performance by the pharmaceutical industry, healthcare system in providing state-of-the-art healthcare during the pandemic, and that was well managed. But unfortunately, we don't have laboratory tests or imaging pictures to make a diagnosis of PASc or long COVID. So several challenges also remain. That is the concern of these authors, that regarding rehabilitation of various physical and mental disabilities of long COVID. And I think there may be a discrepancy between demand and supply of these disabilities. Then actually, I think very important humane effect actually, that sympathetic attitude in providing medical, social, and financial support to patient is required. So take home message, I will say that definition, we don't have any clear cut definition for long COVID. It is still evolving. As I said, there are differences between CDC guidelines and WHO guidelines. So these have not been resolved. Time points are different. There may be, that is the reason actually that we are not very much clear about everything about long COVID. And future global studies using standardized formats are urgently required. Longitudinal follow-up is required. And these omics studies, multi-omics studies are required. And detailed immunological studies are also required among vaccinated, unvaccinated, etc. Biomarkers should be discovered to define course of the disease. We are still actually to get and rehabilitation of various physical and mental health issues. Thank you very much for providing me opportunity. I will be glad actually. I don't know how much I have understood, but I will try to answer if there are questions. Thank you.
Thank you, Prof. Sharma, for the lecture about long COVID. Are there any questions for Prof. Sharma? Yeah, you can take the mic.
Thank you, Dr. Gurmet and Prof. Surendra, for sharing your knowledge. I'm Andri. I'd like to ask 2 questions to Prof. Surendra. The first question is, how do you differentiate between long COVID symptoms that come and go over an extended period and recurrent acute illnesses? Then the second question, considering the widespread discussion surrounding long COVID that in my opinion can have a suggestive effect on COVID survivors, how do you distinguish between long COVID symptoms and psychosomatic symptoms? Thank you.
No, as I said that when I was defining that definition, irrespective of the time, whether it is 4 weeks or 12 weeks, but important thing is that there should be no underlying disease to explain those symptoms, whether these are psychosomatic symptoms or this should be absent. So important rider actually, which I was repeatedly saying that it must be emphasized in italics as I have put it, that there should be no other explanation to explain his symptoms. If you are sure, that is the duty of the physician who is attending or nurse who is attending. And most of the prevalences, as I discussed, that they have inflated prevalence. That is because patients themselves have reported, self-reported. So I think to my mind, one need to have a time with the patient that very careful. I think help from the psychologist, psychiatrist is very important, that they should be able to dissect out.
Okay, thank you, Prof. Sharma. So I think we got 2 online questions. One is from Dr. Shibendu Ghosh. So MIS in adult, if it's long term, can we call it as long COVID? And the other question is, there any genome sequence comparison between short COVID virus and long COVID virus?
As I said, actually, the second question I would like to answer first, that as we came down during that time, as the time progressed, it was very high. That means actually it has been sequenced, the Delta strain and other original strains. So it was much more common. The percentage was very, the prevalence was very high with those strains. But as actually it mutated, the virus mutated over a period of time, prevalence has decreased. And it is very difficult to say whether genomic differences does make a difference or vaccination, etc., availability of oral antivirals, etc. I must point out here, the problem with the developing nation is that they don't have any surveillance data. They don't have electronic proper electronic health records. So we, what I am sharing with you, the prevalence, these are from European countries and North America, etc. So it's very difficult to say what is happening. For example, if you ask me in India, what is the prevalence of long COVID, I will not be able to answer very clearly. Although I have seen scattered cases, as I was mentioning, sharing with you, acute COVID, acutely infected patients, everyone has seen. But we actually, there is a problem with maintenance of records and having follow-up long term. So that actually, because of, I think, basic problem with demand and supply. What was the first question? Surendra Bose.
Yes, sir. MIS in adult, if it's long term, can we call it as long COVID?
Yeah, actually, why not? But actually, the data I have shared with you, this was talking only about adults, not in children. So I have not shown anything about children. The pediatrics is not my specialty, so I may be excused for that. But yes, what I have shown actually, that if there is a persistence of symptoms in adults beyond the SARS acute infection, then actually one can label it very safely, but actually very systematically, because we don't have any lab test to confirm. That is the problem here. So what the one physician thinks, the other may not agree, in fact. And if he is not careful enough to exclude alternative explanation or underlying mechanism to explain persistence of symptoms, so one has to go back to the basics. That means actually history is very important here, because we don't have any markers or tests.
Okay, thank you, Prof. Sharma. So I think we can close the plenary lecture, Prof. Sharma. Thanks a lot for your in-depth explanation about this long COVID syndrome, and hopefully we can give the more better treatments for our patient if they develop long COVID syndrome. Let's give a big applause for Prof. Sharma. Thank you, Prof.
Thank you.